It's one of those calls that can just change life in minutes. You get on scene, you've got an elderly patient, they're confused, and they're crashing. Is it a stroke? Maybe hypoglycemia? Or is it one of the most time-sensitive emergencies you'll ever face? Septic shock. So in this explainer, we're going to break down exactly how to spot it and what to do step by critical step.
All right, let's put you right there on the scene. You've got a 74-year-old woman. You know she has a recent UTI, and now she's just not making any sense. Her vitals are right there. Look, every second counts. What is the single most important thing you do first?
Making the right call in this moment, it's everything. So let's really break down the thought process here. Okay, before you even grab your blood pressure cuff, the story itself is telling you where to look. An older patient, a known infection, and a sudden change in mental status. Those three things together should be setting off major alarm bells for sepsis. Right there, that's gotta be your working theory.
So, with sepsis on a radar, the vital signs now become these crucial clues that help us confirm what we're suspecting. Let's decode what they're really telling us. First up, that altered mental status. Now, this isn't just simple confusion you might get from a fever. In sepsis, it's a critical sign of organ dysfunction. It means the brain isn't getting perfused properly, and that is a huge red flag that the infection has gone systemic. Next, let's look at that blood pressure, 84/50. That is seriously low. We're talking profound hypotension. What's happening is the body's inflammatory response is causing blood vessels to just dilate and get leaky, and that makes the pressure plummet. Her whole circulatory system is failing. She is absolutely in shock. And finally, her respiratory rate. 24 breaths a minute. That's tachypnea. Her body is desperately trying to compensate for the absolute metabolic chaos that sepsis is causing. So let's put it together. Altered mental status, hypotension, and tachypnea. Three powerful clues, all pointing to one single diagnosis. So how do we combine all these clues into a confident diagnosis out in the field? Well, we use a simple but really powerful tool called the qSOFA score. It's designed for exactly this kind of situation. The Q in qSOFA stands for quick, and that is the whole point. It's basically a stripped-down version of a more complex scoring system they use in the ICU. And it's designed so you can use it fast, like in an ambulance or the ER, to flag these high-risk patients without needing any lab results. And the real beauty of qSOFA is just how simple it is. It's really just three questions. 1, does she have an altered mental status? Yes. 2, is her respiratory rate over 22? Yep, it's 24. And 3, is her systolic blood pressure below 90? Yes, it's 84. It is an incredibly fast and effective tool. So here's the bottom line. Our patient hits all three markers. A qSOFA score of 2 or more is highly suggestive of a poor outcome from sepsis. Our patient has a score of 3. The diagnosis is clear, and now we absolutely have to act. And this brings us right back to that first question we asked. We've confirmed our suspicion of septic shock. So out of all the things we could do, what is the single most important intervention we have to do right now? This quote from our source material just gets right to the heart of it. The guiding principle is simple. Hypotensive septic patients need volume. Because of all that widespread vasodilation and those leaky capillaries, there just isn't enough fluid left inside the vascular space to maintain pressure. Our first job is to refill that space, fast. So how much fluid are we talking about? The standard is a rapid infusion of 30 milliliters per kilogram of a crystalloid solution, like normal saline. For an average adult, that's often going to be somewhere between 2 to 3 liters. This aggressive fluid bolus is what's needed to start reversing that shock. So if we look back at our original options, why not the others? Well, vasopressors like norepinephrine, those are for when fluids alone don't work. Antibiotics are absolutely critical, but you can't kill bacteria in a patient who has already died from hypotension. Stabilization comes first. And dextrose isn't needed. Her glucose is totally fine. The only answer that addresses the immediate, life-threatening problem is the fluid bolus. Okay, so starting the fluids is step 1, but we can't just set it and forget it. What's our goal here, and what are the risks we need to be watching for? Our main target is to get a mean arterial pressure, or MAP, of at least 65. You can think of MAP as the average pressure that's actually pushing blood to the organs. If it drops below 65, the brain and the kidneys are really not happy. But this is a balancing act. We have to be constantly listening to the lungs for crackles, which is a key sign we're giving too much fluid. So this really makes the treatment sequence crystal clear. Fluids are always first. You have to fill the tank. Vasopressors, like norepinephrine, they come second. We only use them to squeeze the vessels and raise the pressure if the patient is still hypotensive after we've already given an adequate amount of fluid.
And finally, let's just touch on antibiotics. I mean, it seems intuitive, right? We should give them as early as possible. But what's interesting is that the evidence still isn't totally clear on whether giving antibiotics in the pre-hospital setting actually improves mortality. It's a good reminder that we have to follow the evidence. So for now, the takeaway is simple. In suspected septic shock, use qSOFA to spot it early and hit that hypotension hard with fluids. That is your first and your best move.